part of OPIC, and my PhD's in clinical social work, and so I have some experience in mental health and behavioral health and substance abuse, and some time in the military providing behavioral health and those kind of things. And so I'm happy to talk with you today about this zero suicide. And we'll go through the slides, and then, the other thing we can talk about is the implementation. The practice facilitators will do a lot to work with you to help you facilitate this. And if there's any additional training that I can provide for you or work with you in terms of the implementation of the workflow or some of the evidence-based things, we'll be happy to do that. But we'll go through the slides, and I'll stop periodically and ask for some, if anybody's got any questions, and try to answer those. And at the end, we'll probably have some time too. So we'll go ahead and go through this unless there's some question or comment anybody has, Kathy, or anything you want to add.
I think we're good, Dr. Brand.
All right, so let's go on to the next slide. And this is a short video that goes over some of the basics. So we'll go ahead and watch it real quick.
Every minute of every day, suicide impacts the lives of hundreds of people across the globe. It robs families of loved ones, young people of their future, workplaces of colleagues, and communities of their most valuable resource, their people. And surprisingly, of the 800,000 people a year worldwide who die of suicide, most saw a healthcare professional in the year prior to their death. Contrary to popular belief, the problem isn't that those at risk are disconnected from healthcare. It's that gaps exist that allow these individuals to slip through. Despite this, healthcare has remained unchanged, presuming many deaths were tragically inevitable. Inspired by the Henry Ford Health System in Detroit, Zero Suicide is a call to action based on the belief that no suicide is fated. It all starts with zero because a radical and systematic approach to perfection is the only way to create dramatic change, and it must be driven by leadership's commitment to creating a new culture around suicide prevention. 3 specific evidence-based interventions have emerged as central to Zero Suicide, creating the multi-layered approach that helps ensure no one slips through the cracks. First, we must make it okay to talk about suicide. Healthcare must routinely screen for suicide risk at all patient touchpoints within a health system. Simple screening questions like, do you have thoughts that you'd be better off dead or hurting yourself, allows healthcare professionals to start a conversation about suicide, create a connection, and acknowledge the anguish and pain. The simple act of asking about suicide risk is more predictive of a future suicide attempt than even cholesterol scores are for a future heart attack. Second, the strongest resource in preventing suicide is always the person at risk. By collaboratively designing safety crisis plans that include reducing access to lethal means and following up with phone calls after discharge, one recent study showed a 45% reduction in suicidal behavior. And third, we must treat suicide directly. We've assumed that treating mental health and/or addiction will fix suicide risk, but that doesn't always remedy the pain that underlie thoughts of suicide. Zero Suicide trains health professionals to deliver specific treatment, as well as caring and supportive contacts either between appointments or as post-care follow-up in the weeks and months to come. This relentless pursuit of perfection and insistence on evidence-based intervention works. Henry Ford saw a dramatic 80% reduction in suicide and maintained that success over a decade, including 1 year when they actually achieved zero. And at Nashville-based Centerstone, one of the largest nonprofit community mental health programs in the U.S., they reported a 64% reduction in suicide deaths since implementing these initiatives. And on the other side of the world, Gold Coast Health in Queensland has succeeded by utilizing the resources of the Suicide Prevention Resource Center, including a specific toolkit with a set of practices and resources for data collection and continuous quality improvement. Additionally, thousands of other organizations around the world are now taking their first steps towards zero suicide. Bold visions have put a man on the moon and cured polio. For suicide prevention, there's no more time for half measures and missed opportunities. Only with insightful leadership committed to the pursuit of zero suicide will we be able to make significant strides towards eradicating these tragedies. Zero Suicide, healthcare that believes no one should die alone and in despair. Every minute of every day, suicide impacts the lives.
Thanks, Kathy. So that brief presentation goes over a number of the kind of significant facts that we'll talk about, or points that we'll talk about here in this slide presentation. But to mention just a couple of them, one is the whole idea of zero suicide is that it becomes a organizational initiative led by leadership, and that zero is a number. It's the number one, I mean, it's one of those preventable deaths. It's obviously preventable, but we have to have that mentality that zero counts, and zero is what we're looking for, rather than sometimes that happens and there's nothing we can do about it. We'll talk a little bit more about how folks come into contact with healthcare providers. Approximately, 45, 50, 60%, depending on who you're reading, come in contact with a healthcare professional, sometime within the first year or 2 weeks before actually in a suicide attempt. And not all those folks are seeing mental health folks. About half of them are seeing mental health providers, but the rest are not. So this idea that, which leads us to the idea that, we should ask. That's universal screening is one of the things we talked about. So the idea that we need to screen universally, and it's okay to ask. And when we ask, people will respond. And then if we, have the right evidence-based approach, we'll be able to prevent suicide. So it's a very preventable kind of thing. But look in there at that third, fourth bullet. It's interesting, sometimes as healthcare providers, we get in the mindset that, if we ask, that somehow will offend the patient, or the patient will be upset, or the patient will leave the practice or something like that. But actually, when we survey and look at patients, they really expect the physicians and the healthcare provider to ask about how things are going in their lives, and other, psychosocial aspects of their lives, and how that might impact their health. So I'm a behavioral health provider, so I'm used to talking about those kind of things, but sometimes other types of providers are not as comfortable asking about how things going at home or how things going at work, those kind of things. So getting in the habit of screening and getting in the habit of asking. And then lethal means there. So, one of the things we want to do, obviously, if somebody's at high risk or they're having some kind of suicidal thoughts, is to remove lethal means. And for most folks, particularly in Oklahoma, that would be firearms. But there are other kind of lethal means we might want to talk about. Now, then that third bullet's important because, sometimes there's this myth that if you're going to do it, you're going to do it, and you're going to just continue to do it. And that may happen sometimes. But by far, people who attempt suicide don't attempt again. And if you spend any time on our trauma unit there at the Health Science Center, that a lot of people come in with the suicide attempts. They tried to shoot themselves and only shot half of their face off, or something like that. And their chances of suicide are not great. And sometimes it's a very impulsive kind of thing, and it's like it's an urge. They talked about it in the videos, an urge. And so it's a strong urge to do something. I think the common is a permanent solution to a temporary problem. So this idea that, it's this brief, intense period. And if you can get through that, chances are, you may rethink everything, and things do get better tomorrow, the next day, or the day after that. And people don't want to suicide. Now there's some subsection 10% here with mental health problems that get locked into something like that. But most of the time, people want to live rather than die. They just don't see any way forward. So we can help them through that. Okay, yeah, I think let's go to the next slide. I think we covered everything there. So here's some principles. And so this is a systems-wide approach. So it includes the management, it includes the leadership, it includes a quality improvement piece, and it includes frontline staff being trained and supported, and a management system. So these are the core values, that the idea that suicide doesn't have to be. And like the video showed, and we'll show an example a little bit later in Oklahoma, you can really reduce suicides from happening, and there's a cost savings if the program is properly implemented. It's a systems management approach that needs to be from the top down. It needs to be led by leadership. It needs to be supported with policies and procedures, And then an improvement, performance improvement piece or quality improvement piece to take a look at the data, be data driven, kind of know where the problems are, what kind of things you can implement to improve the outcomes. And then evidence-based practices. So there's a number of evidence-based practices. I think the video talked about CBT and dialectic behavioral training and some of those kind of things. So there's some specific kinds of things that we can do that are evidence-based that will make a dent or certainly improve the problem and cut the suicide rate down. We'll talk some more about that here in a little bit. Okay, Kathy, next slide. Well, before we go there, before we get into the elements, any questions or comments about your own practices or about the program or what we've talked about thus far? We're good? Okay. So these are what? 1, 2, 3, 7 elements. Kind of makes a circle up there at the top. And we're going to go over these in a little bit more detail. So I won't spend much time on this slide, Kathy, so we can go on to lead. So lead is this idea that this is a systems-wide approach. It's not just, the providers are going to do one thing, but the whole practice is going to get training, is going to be educated, and is going to put their effort behind this zero suicide effort. So things like meetings and leadership, finding some champions and leadership, taking a part, putting their weight behind it, the time and energy that it takes to develop policies and procedures, MOUs with other providers, and do some training. So it's an approach that needs to be led from the front by the leadership. So we can talk more about that. We'll talk more about the PI piece of it here in a little bit. But Kathy, I think we can go on to the next one. So training is a big piece. And with training, what we're talking about is improving, the practices frontline individuals and clinicians with skills and confidence so that they can become good at identifying folks that are at risk for suicide and then how to intervene appropriately. So everybody receives a basic kind of training and introduction to the program. And that includes the philosophies. And then if a practice doesn't have policy and procedures, then Cheryl or Kathy or one of the facilitators can work with the practice to develop policies and procedures and protocols and workflows that'll help ensure that the zero suicide plan gets embedded into the workflow of the practice. And the staff can work with you some in terms of your practice, in terms of basic research and training in suicide identification, and then additional training for folks who may be actually trying to develop a safety plan and working with folks or making referrals and following up with people who are actively suicide or at least at high risk. And then the last thing there at the bottom bullet is training. So everybody gets trained at their level. Everybody understands, everybody buys in. And then you have refresher training and you have training for new employees that come into the practice. So they recommend at least every 3 years, but every year to 2 years, probably it's good to review in some form or fashion. So these are the core elements to train. We can go on, Kathy, to the next slide. And this is really one of the core features of zero suicide, and that's the universal screening or screening for suicide risk. And there's a various instruments you can use. In our practice, we use the PHQ-9. Some people use the PHQ-2. There's a Columbia, which uses a kind of combination of those. So the idea is that we're gonna work into our workflows and our policies and procedures that we screen, universally 100% of the time, and then we're able to identify those folks that are at higher moderate risk, and we're able then to address that. A lot of people who score moderate to high won't require any intervention other than we've screened and you have, you're working with somebody or you're doing something or you're taking action and your risk factors are not too great and there's some protective factors that mitigate. And we just want to track and support the folks in our practice. So that's kind of the idea here. But we want written policy procedures and workflows and how we screen, whether we screen on tablet, we screen on paper, how that gets collected, how it gets handed off to the clinicians, to the nurses, the providers. And then if you do find somebody who's moderate or high, what are you going to do? Kathy, if we can click that Columbia, I'll go over a couple of things. This is really a nice website. And like I said, I, the other staff, faculty, OFIC are happy to work with you on going over some of this or working out. So if you scroll down, Kathy, let's scroll down here a little bit. So these are the people who've recommended and endorsed it, but keep on scrolling down. And we're going to scroll down till we get to healthcare. There it is, healthcare right in the middle. So let's punch on healthcare. Let's click there. All right. And then we can go scroll down. It's going to tell us some stuff we already know. 50% of people who die see a primary care person. These are some of the principles, saving lives, and it's simple and it's efficient, effective, universal, so forth and so on. We talked about some of that. But you can look at that. Keep on scrolling. And then go to the get. Yeah. And keep on scrolling. Now, this is the thing that we can work with you in terms of your practice about how you integrate. Hang on just a second, Kathy. We can work with you on this, whether it's training or implementation or, doing the training with you through the Columbia. We can do any of that. Let's look at two things while we're here. Click on the Columbia Community Card for Health Professionals. I have some of these in my office. I think you can order these. If you just kind of scroll down that PDF, this is the kind of thing you can have in your office. And so for frontline folks, as a universal screening, it'll walk you right through it. So you see you got these two initial questions. Those are kind of PHQ2 questions. Have you ever wished you were dead or wished you could go to sleep, not wake up? And then the second was, have you actually thought about killing yourself? And so you can see there, it's very simple. If yes to 2, then you're going to go 3 and 4 and 5, 6. So, and if you're yes to 2, which means I'm actually having those thoughts, you don't need to ask those middle questions. You just skip down to, have you done anything to start or prepare to end your life? So this is a planning piece. And so the middle questions, how long have you been thinking about how you might do this? Or any thoughts? So these are kind of teasing out some intent questions, some lethality kind of questions. So we can back out of that, Kathy, and go back to go back to Columbia. I want to show them one other thing because this helps explain how we kind of do this. So go back to where, okay, out of the PDF. There you go. Let's see, evidence-based full cell. Scroll down a little bit more if you can. Hang on just a second. Okay, go to the risk and protective factors page. Yeah, there you go. So this is a good one just to kind of, and if you can blow that up a little bit so we can see it. This is the kind of thing you're going to get from the Columbia. Maybe you can't, but where you're gonna, this is suicide, self-interest behaviors, and still lifetime and in the past 3 months. So those are 2 timelines we look at, and then you're going to talk about, what kind of ideation, what kind of thoughts have you had, and activating events and those kind of things, and then any kind of treatment history. But over on the right, then you're going to take a look at clinical status. Have they had any of these kind of things? And you're going to look at positive factors, things that are protective, and those kind of things. So the point of, you can back out, like Kathy, and go back to our slideshow. But the point of walking you through this is that Columbia has a lot of resources that you can work with on your own, or we can help you figure out how to implement those and which ones might work for you and how you might use them. So there's a lot of resources there with the Columbia. And I think, Kathy, that correct me if I'm wrong, but we'll make this presentation a PDF and send it to you, and have all the links and all that kind of stuff in it, so you can look at it yourself when you have maybe more time. Okay, let's go to the next slide. We've got to identify. So once we identify somebody, then we got to engage. And engagement means we're not going to just look at a score. We're going to ask them what's going on, and we're going to hear it in their own words. And then if we need to, we're going to kind of escalate the intervention based on the severity. So we may need to involve family members, or we may need to ask if there's firearms. And a lot of times, if somebody knows that they're having thoughts about hurting themselves, they have firearms at home. Sometimes I'd say 60, 70, maybe 80% of the time. If you say, well, wouldn't it be a good idea if somebody else held on those for a little while? And they'll say, you go, yeah. So they'll have a son, or they'll have a cousin, or they'll have a family member, or something like that, that'll come over and get the firearms and kind of hold them until things get better. And it's not like you're never going to have, never going to get your firearms back. You can also sometimes involve the sheriff's office or the police and ask them if they will hold somebody's weapon. That's becoming more common. Years ago, before we did this, I had a patient that was suicidal and I asked him to take his guns to the police department. I forgot to call the police department to tell him. Luckily, this was a long, long time ago. So he's walking into the police department with a couple of firearms. So that got their attention. But once they kind of understood what was going on, they were happy to hold his weapons in the armory until he was ready to get them back. So, and sometimes then we need to send people on to a psychiatric facility or have them evaluated by a psychiatric professional. So if you can, and you're not on your own in doing this, but if you click that CALM, that's part of the Zero Prevention website. We're just going to look at it so you can see it. But this is some training that you counseling on access to lethal means. And so you can scroll down there, Kathy, and kind of show folks. It's a course. You can take it online or you can pay some money and they'll come give it to you. But basically, it's how to talk with people and make an assessment and kind of make sure that they're going to be in the safest environment possible. So we could certainly help you with that too. So you can see the workshop version. It's a little pricey. They're about $3,000 to $5,000 plus travel. So, but the online piece is good, and you get a certificate of completion. So it might be something you want to have some of your staff do, and it instills some level of competence and preparedness to deal with this, which is always good. So we can go back to our slides now, Kathy. All right, so there we go. So then we're going to do this treat. And so the treat really is get the person to where they need to go. So we've identified, we've engaged, and now we're going to treat. And basically this is getting to the person to the least restrictive environment possible. So if we've done kind of an evaluation or kind of initial assessment that we feel comfortable with, and we figured out level of care, severity of illness, those kind of things, then we kind of know how to match them to the level of care. So whether that's outpatient counseling, that's an evaluation, that's a safety plan that you've created, with them and with their family, or whether it's using the 988 number and getting somebody to a psychiatric facility or getting law enforcement involved if the person is not cooperative but intent on hurting themselves. So we look at the safety plan. Now I want to go over this Brown Stanley safety plan template. So we can click on that because this is a neat little deal. And so I'll just want to walk you through this. It won't take very long, and you can see how easy this is. So you can have a nurse, you can have a social worker, you can have somebody in your office actually sit down with the patient who's moderately or at some high risk and have them do this. So let's make a plan. All right. So this is what's going to pop up. So this is going to be, what are the warning signs? So Kathy, click on those and click a couple of those. So let's see here. So what are my warning signs? Maybe it's crying. Maybe it's not eating. I don't know. Kathy, you pick one for the next one. And then we go to next. And so now we're going to talk about what are some coping strategies. So you're sitting and talking briefly with the patient. They may like to listen to music. Maybe the next one is they like to art or something like that, or whatever it happens to be, Kathy, you can pick the next one. All right. And so then we go to next. So we got the coping strategy. These are kind of things you can do, a person can do to distract themselves if they're feeling like they're having these thoughts. So any music, Kathy, pick a couple more there. And okay. And then we're going to go on to next. And so now we're going to, who are your supports? So these would be your social supports. These are like your family, your friend, your mom and dad. So Kathy, pick some of those that you think would be good social support for somebody who might have some thoughts about harming themselves. Great. Okay. And then we're going to next. And now these are going to be professionals. So you might have your shrink on there. You might have your priest on there. You might have a school counselor on there. Just whoever you want to pick there, Kathy. All right. Then go to next. I got them. Now go to next. And these are going to be environmental kind of things. So what do I need to avoid? So maybe I need to stay out of the kitchen, stay away from knives, sharp objects, firearms. So here you go, Kathy. Pick some of those. All right. And then we're going to go to next. And so here we go. So now then we've got this that we can print out, sign off on it. The patient takes it, the family members take it, and it's initial plan. And you can also put in there some phone numbers or the 988 number or hotlines, your number. I mean, whatever you want to put in there, and you can then transport that to the chart, or you can print it off. So that is a neat little tool that's very easy to use, very user friendly. It can be used right there in the office. So I wanted to show you that, because sometimes, and it's, for somebody who is, eminently suicidal and not necessarily cooperative or thinks they're at the end of the rope, obviously those people need a psychiatric evaluation, being admitted to the hospital, seen in the emergency room. But for people who have moderate or higher scores, who are not actively suicidal and have some protective factors, certainly you could use this plan. And one of the things you want to do then is follow up. So let's go back to our slides now, Kathy. Any questions so far from anybody? Or any comments that anybody has, or stories, or anything like that? All right. So so now that we're talking about transition, so we've identified somebody that's moderate or higher in terms of some risk for hurting themselves. And so now we need to ensure this transition, so that you can see there, bullet 2, it's primary care to behavioral health, back to primary care. And so we need to make sure, like the video talked about, people don't fall through the cracks. And so here's where your practice facilitators can work with you to get MOUs developed. You can talk about how you can leverage telemedicine. If you don't have a provider in your practice or one in your community that is available, then you can take a look at some telemedicine arrangements where you can have the person evaluated, or have a qualified mental health professional take a look at the person and make some recommendations. But the main thing is we don't want to just tell people don't do that and then send them on their way. We want some kind of connection with them, so that they have a plan, we have a plan, and we're following up. And sometimes it's very simple kind of things, like I'll call you tomorrow, call you tonight, and make sure you're okay. You just have the nurse call and say, how are we doing? They say, well, we're home and everything's better. And Johnny got the firearms and they're out of the house, and, he's resting, or she's resting, it's like simple kind of stuff. And it's reassuring to the patient and the family. And then you call back a day or two later and say, did he go to his appointment to see his counselor? And he says, yes, he did. And things are better. So you just want to track that. If they have to go into a program or into a treatment, then you want to just make sure that you're tracking that. Now, we had a question the other day about, on universal screenings and on this transition piece, what if somebody in your practice, you already know that they're seeing a counselor downtown or something like that for depression or anxiety or whatever it happens to be, and they're going to come back through your primary care practice and they're going to get screened again? Is that going to be offensive to them? My thought on that was, no, it's not offensive to them. They need to be screened, and hopefully everything's going good. And there's releases of information. And the primary care practice and the mental behavioral health folks are talking to each other, and it's kind of a team approach. And it's not like I'm going to step on your toes or I'm going to offend you by asking. And in some cases, in some smaller communities, you might have psychiatric prescribers available. And so you may need the primary care practice folks talking with the behavioral health practice folks about what medications, or would an SSRI be good here, and how's the patient responding, because the behavioral health folks usually see them more frequently sometimes than primary care does. So no, I don't think it's offensive for the patient to know that the primary care practice and the behavioral health guys are talking to each other on a regular basis. And if they get screened on both times, that's okay too. And if everything's going well, then we just go on. But if somebody's falling through the cracks, or if they're having a particularly difficult time, remember those suicidal thoughts usually come in waves of urges. And so you might just be catching the patient, they may be doing fine in their behavioral health, working on their marriage, working on trauma, working on whatever. But on that day, something happened and they're just feeling particularly low, and the thoughts come to mind, and you may just be catching them at that time. And it's okay to screen, and then it's okay to say, hey, I think I'll reach out to your behavioral health guy and let him know what's going on, or can we do that together? So anyway, this idea about transition is really about tracking and managing the patient jointly through the primary care need behavioral health assets that get involved. All right, Kathy, we can go to the next slide. Here again, we're talking about safe transitions. It's the same kind of thing. And, one of the things the Zero Suicide program recommends is MOUs with behavioral health providers in your area, which would be like agreements that they would see the patient or try to see the patient within 24 hours, or that, they could get it first available, or if you have telemedicine available, that maybe somebody will, you can keep the person there in the office, and, somebody will get on telemedicine and talk with you and evaluate the patient, do a mental status and talk with them. Or, maybe with the mental health professional through telemedicine, you'll work out a plan or whatever. And you may, depending on where you're located and what you've got in terms of resources, you may want to look at MOUs with different levels of providers in terms of levels of care, severity of illness. So if you have somebody who needs to go to I don't know, maybe you don't have a hospital close by, you don't have an ED, but maybe you have an urgent care center. So maybe you'd be working with them about how to manage the patient. But anyway, we could certainly help you with that and see what resources are available in your area. The other thing is kind of, leveraging your electronic medical record or your health record and seeing if it, works across practices. So, you're able to look at each other's records and see what's going on. But so the transition of care and then the policies for the transition of care. So we want to establish this kind of smooth process. And like the slide says, you can use text messages, you can phone calls, postcards, you can use all kinds of things to follow up with your patients. And really, once somebody has been identified at risk, wherever they are on the continuum from mild to moderate to severe, we think we need to intervene. We want to do something within 24 hours, really is what we want to do. We want to make sure they get to where they need to be, or the plan is in place, or the appointments are made within about 24 hours. So this coordination is a big piece, and sometimes that's a real challenge. So we're happy to help you with that. Okay, so let's go to the next slide, Kathy. And then improve. So improve is the idea that we're going to collect data. We're going to leverage our electronic medical record to be able to pull data. We're going to see how many folks we've screened, how many actually had some intervention was necessary. We're going to find gaps, and we're going to come up with processes for improvement. We're going to do little mini experiments to see if we can improve on our process, with the goal being, better care for the patients. And we're going to just keep that process going. Lean Six Sigma is, what, 96.666 or 99.666. So we're really shooting for zero. But the idea is that we're going to use a performance improvement plan to monitor and track and benchmark what we're doing. And we'll go over an example here in Oklahoma in a minute. And, it took some time to implement it, and it took some time to improve it and keep it going, but it paid off well for one of the tribes here in Oklahoma. So that's the improvement piece that involves your office staff, your medical records folks, and an interaction between your senior leaders, your providers, and your support folks. So, all right, next slide. So this is it's hard to see, but this is a example of suicidal kind of element data worksheet that you might collect. And you can see you got the mission. I can't read that very well. And the numerator and the denominator. So this is where you're trying to get your odds ratio to figure out, how you're doing. So, yeah, you can look at that core elements worksheet. I think it's a spreadsheet. And so this would be the worksheet that they would do. We would help you set that up, figure out how to pull the data and those. You can scroll down there, Kathy, we can see it's just kind of instructions on how to do that. I'm sure most of your operations people would know all about how to set this up. So, all right, so we can go back to our slides and go to the next slide. So one of the things the practice facilitators can do, and we can help you with, is develop kind of your workflow. And so that would include, what screening instruments you're going to use and where you're going to screen up front, Is it going to be electronically computed or it's going to be hand computed? And where does that go? And if you need a plan, where do you get the plan and is it available? And, those kinds of things. But this is an example, right here in Oklahoma, the Chickasaws, click that zero suicide there, link there at the bottom. And we kind of scale through, kind of run through some. This is the Zero Suicide website. And school on down there a little bit and just show folks kind of what they did. They used a universal screening instrument. It took some time to get it implemented. They were running about 120 to 150 inpatient referrals. I think that was a year before they started. And those were costing about $11,000 an admission. So when they got, let's scroll up a little bit, Kat. Let me see if I can find the exact number on that. Let's see, hang on. So between there, yeah, so you can see their bullet key outcomes. So there it was. So they're averaging 120, 150 suicidal patients admitted to inpatient unit per year. And between 16 and 17, they implemented and they started using this universal standard screening, using risk assessment, safety plan, just the same things we've gone over. And as a result of that, they were able to divert 200 from admissions to inpatient units. So that ended up, that's quite a savings of about 200,000 per year. So it had really economic, tangible, and of course it was better for the patients because those 200 folks that were diverted, they didn't need that level of care. So they reduced stigma and got more of the care they needed at the level that they needed. So again, it's that severity of illness level of care things. Kathy, you can kind of scroll down there, kind of let people see what's in here. But this is an example from Oklahoma. We saw about what happened at the Ford Center and their Cornerstone in Tennessee. But so they got the screening and the assessment and how they implemented that and the safety planning and then what they did to follow up. And then these were the implementation outcomes that they used. And you can see there's some of their data that they, so they did, so 16 to 17 greater than 125,000. And so actually once they implemented in October, the screenings went up, but not much. So they were already kind of doing a pretty good job of screening. And then they used the Columbia quite a bit more. Anyway, cost savings. So you can go to the website, the Zero Suicide website, and you can see some of these exemplary kind of cases that are out there that might well apply to your situations as well. So there we go. So all right. So I think that takes us to kind of the last slides, which is the Zero Suicide kind of brochure that you can go to that website there, and it'll give you all that. It'll give you the brochure if you want it. You can print that off. There it is, and you have that, and then yeah. So going on to I think it's the last slide now, Kathy. These are some additional, we don't have to click on these. These are some additional, we've been over several of these. These are some additional resources that'll be in the handout that you get with the PowerPoint. And that's about it. I mean, my job is the easy one, which is just to tell you about it. The more challenging job is to implement it in your practice. And our practice facilitators and myself can help you with that, or training, or any of those other kind of things that you may need. So we've got time for questions or comments or stories or any of those kind of things. So we can take whatever questions or comments we need at this point, Kathy.
Anyone have any questions for Dr. Brand? We have about a couple more minutes to reach the hour.
Well, I went over that pretty quick, kind of the 1, 2, 3s, but those are the 7 elements. They kind of flow together pretty nicely. Let's see here. Heather says to everyone, as a new provider, I think the biggest challenge is finding mental health providers to see the patients. Yeah, that is a problem. So Heather, where are you located exactly? You're in Tulsa? Yeah, so do y'all have behavioral health guys in your practice? Okay. So that might be where, you might look at helping or, helping you explore what are some relationships you might want to have or could have with behavioral health providers or facilities. Particularly those folks with higher acuity that need to be seen immediately or pretty quick, at least, where you might be able to send them or how you might be able to address that. But yeah, that's a problem in a lot of places. But I would say that, with practice and training and a system, you can probably address, a lot of stuff at your level, probably more than you might think. But that's a good question. That's a good comment. What else? I need two more to feel like I've done my job today.
Hi there, my name is Molly Collins.
Hey,
I'm
Molly.
the executive director or practice manager of Family Healthcare Clinic in in Bartlesville, Oklahoma.
Mhm.
I do want to go. One of the things is we have a provider and a nurse. That's who sees patients every day. There's nobody else but them. Obviously, training can start from people calling on the phone, requesting appointments, and even my front can assess them real well, or if we have patients miss and they have had, scored a certain way on the depression, anxiety screen, mental health screen that we can do all that. But when we have a patient in the clinic who scores a certain way that requires an immediate intervention, so for example, whether it's to get the Bartlesville police out or to get Grand Mental Health, which is our mental health, I wouldn't even say partner at this point. They're just
Yeah.
somebody we call, and they bring over a tablet, which gives us the ability to figure out whether they're ill enough, I guess, to be
Mhm.
receiving more services, but it stops the practice flow 100%. And since we see maybe 8 to 12 patients a day, we're a slow flow, very patient focused clinic, not a 501c3 nonprofit. What we're finding is the biggest challenge probably in the last 4 months is that they're important, but it stops everything. And so we're not necessarily sure. And mostly what we're looking is resources to be able to sort of like be able to have somebody available, kind of like a community health worker or a social worker, that would then take that patient on and figure out what exactly they might need and interface with the rest of the world while the provider and the nurse are still in the clinical portion of it, because that still has to happen. We don't want to disrupt the flow. So I don't know if you know of any resources that would help with, additional staffing or additional something that will help the patients that are certainly in need, but we can't always address it because we do ask every patient for the most part about their mental health status, which has been a part of our practice for years. But what we're noticing the last 4 or 5 months is that more of them are marking extreme mental health issues as well as suicidal ideation. So I'm just curious.
So, yeah, I mean, I think that's always a problem was, you got a small practice and it's click, click, click. And then, something like this happens and it blows your day up. So, so are these folks that need like I guess I got, this is a multiple choice question, and
Sure.
maybe yes to all. I mean, are these people that it's obvious you need to go to a psychiatric hospital or emergency room now? Are they people who are like, have, moderate to high, thoughts of hurting themselves that could be handled at the local level if handled well? Am I making any sense?
Right. So my nurse is sitting right next to me and
Yeah.
she's the one who interfaces with them and responds with them when they have that. So I'm going to leave that clinical question to her.
So if they check, they feel better off dead more days or several days, then we call the police. We were calling the police. They bring out their iPad and it would connect us to Grand Lakes emergency hotline. And she would discuss with the patient in the room that, what's going on, if she needs to be seen or not. And they make the decision if they're critical that they need to go right then, or they're okay, just give them meds with that from my provider and go from there. And a lot of times we were calling the police a lot. So then we called Grand Lake to see if their counselor could come talk to them. And they started doing that to get rid of to remove the police because a lot of our patients have warrants or, in trouble with the law.
Yeah, right.
And yeah, so I'm not sure where we need to go because the police were coming in, they'd been there maybe 5 minutes and then they'd be out and say they don't meet criteria. So it's
Yeah.
just, and we're struggling connecting with Grand Lake. They don't want to give us any information about our patients, even if they sign a release, confidentiality release. So we feel like we're just our hands are tied.
Right. Yeah. I mean, a couple of, knee-jerk reactions of what you're saying is, it might be helpful to do something like the Columbia training so that you might feel more confident in terms of, this person, they're having suicidal thoughts. They've been having them for a long time, but there are some mitigating factors, there's some protective factors that are protective. In other words, keep them from acting on whatever thoughts they're having. And as long as those are in place, you're probably okay. If they're not in place, then, you got a problem. And so that might be, where you come up with the plan and you come up with some phone calls and you come up with the referral, and then you just kind of track and monitor. And if something changes, then to get more aggressively involved.
Okay.
And then the other thing is, I don't understand, like I said, there may be reasons I don't understand, but I'd be interested in talking with Grand Lake and their executive director, whoever it is over there, and like, these are these are all our patients. I mean, they're your
Right.
patient, they're my patient. I'm primary care, you're mental health. You may have psychiatry, you may not. There's nothing in the Federal Registry or in HIPAA that says you can't talk about a mutual patient. So
It's very frustrating.
Right, it's very frustrating. And so sometimes there's this. They may have a side to the story too you need to hear. I don't know.
Right.
But I'd be interested in some, kind of face-to-face let's talk about these patients that are in our catchment area that we've got to take care of,
Yeah.
And how can we take care of them together, rather than two ships passing in the night, and hear what they have to say and see if you can't work out some MOU kind of arrangement, see if you can't work out something.
Okay.
You might do well with some Columbia training to really, figure out, what are risk and protective factors and what are the kind of things, that you need to ask. And if they're positive, it really puts you in a different zone versus, I've had these thoughts for the last 5 years. I'm not acting on them. I got to take care of these kids and I go to church and I have all these reasons why not to, but yeah, I do think about it. If I didn't wake up, it wouldn't be a big problem. Or if I got hit by a bus, it'd be no problem. Nobody'd miss me. Or, I have, why don't I just run my car into that tree? How, so there's some questions and follows, you might be able to expand your capacity a little bit there to better assess and feel supported in your documentation and your recommendations based on some additional kind of training from the Columbia. So that'd be one
Okay.
thing.
That's good. Thank you.
Yeah.
I do want to give both of them props, and just one happy story. We did have a patient
Good.
years ago who expressed some suicidal ideation, and the nurse that's sitting next to me basically talked them through the issue, and they were like, well, if you did that, then your dog wouldn't have an owner.
Yeah.
And essentially it was the dog that saved that person's life. So they try real hard, but it was just a real interesting, that was the lock and the key for that person was the dog. So you never know, that additional training you mentioned would be great for us for sure. So appreciate it.
Yeah, trying to, the calm training would be helpful too, I think. But also, learning how to do it and figuring out what the protective factors are. So if the dog dies, you got a problem. But as long as, so you start every time they come in, how's the dog? So as long as the dog's okay, they've got a reason for living. So maybe they don't need to go have the police come see them or be evaluated for an inpatient admission, as long as you got confidence that they've got reasons to live. And they're, isolation is also one of the problems. So just staying in touch with the patient, giving them extra call from time to time frequently is important as well. Just some monitoring. So anyway, so that's a good question. Good story. I appreciate that. Any others?
There's a
All right.
comment in the chat from Wellsprings. Dr. Brand, that is a great information on the common mitigating protective aspects.
Okay, good. Yeah, I think it's just kind of a training issue. Okay, Kathy, what else do we need to cover? So you'll make the presentation available to a PDF or whatever to folks, and they can look at those links themselves. And if they feel like they want some training or some practice facilitation help or something like that, you'll be able to coordinate that.
I can coordinate that, and I also recorded this so that I'll send them a recording as well so they can have something to look back and review. But
Okay.
great discussion, everyone.
Good. Okay, guys, hopefully it warms up and the sun comes out and we're able to get out of our house one of these days soon. So have a good week. I enjoyed it, Kathy. Thanks a lot, guys.
Thank you, everyone.